we go on to our next speaker, Dr. Jayagayathri, who's the Chief of the Orbit and Oculoplasty Services from Arvind Eye Care Systems based at Pondicherry. And she's going to take us on unveiling the complications in ptosis surgery. On to you, Dr. Jaya.
Warm good evening to the august audience present here. Is my screen visible, ma'am?
Yeah.
Okay, I have my heartfelt thanks to you, ma'am, for giving me this wonderful opportunity. After hearing Shruti ma'am's excellent talk on complicated ptosis, I'll be covering the complications that we encounter in ptosis surgeries. As usual, the classification can be pre, intra, and post-operative. Pre is most often a misdiagnosis, which ma'am has illustrated very well. The commonest being myasthenia, the missed strabismus, that is the double elevator palsy, and of course the unrealistic expectations either from the patient themselves or from the parent of the patient in case of a congenital ptosis. So pre-op counseling becomes very, very important. Sometimes we need to deliberately undercorrect. So that should not be taken off as a complication. Intraoperatively, the common one can be hematoma, especially in these situations where the patient is on aspirin and we had a huge hematoma which was not revealed, and next day we had to encounter a huge hematoma. There rarely in novice surgeon there can be an inadvertent injury to the globe, but the conjunctival buttonhole, especially during LPS resection using the anterior approach, is not uncommon. The postoperative complications usually undercorrection, overcorrection, lag of thalamus, poor lid contour, and the asymmetric lid crease are little common, whereas ectropion, entropion, the eyelash ptosis, conjunctival prolapse, the lamella granuloma, and the suture exposure are little uncommon. The undercorrection, it can be seen either with a dorsofrontal sling or with an LPS resection. The most common causes being loosening of the inadequately reinforced facial knots, failure to raise the eyelid adequately before placing the facial knots. But it can be easily overcome if it is a dorsofrontal sling, because we can open up just the forehead wound and the sling can be tightened at any moment of time and the desired height can be. Action is a little risky because it leads to corneal exposure and keratopathy. In this young girl who was about to get married, there was an overcorrection following an LPS resection and we had to resort to LPS recession. So we can obviously see two scar marks following two surgeries. So the trial of massage was done. Usually it is done in the first week of surgery. The downward traction on the lashes or even the lead diversion over a demerist retractor on the hospital setup. If it is not working, then through the transconjunctival wound, we can reposit with a iris repositor if the posterior approach of LPS is being used.
Hello?
Yes, ma'am?
Sorry, carry on, Jayagayathri.
Oh, okay, Vidya. So if there is 2 mm of lid retraction, we can handle it with a genotomy. If it is 3 mm, we can do elevator recession. But if it is really 4 mm or more, then we may have to do a scleral graft. But if it is after a tarsofrontal sling, then we can just loosen this sling or cut the sling and redo it. Lag of thalamus. Lag of thalamus is a part and parcel of any ptosis correction. But as Kasturi madam said, the newer frontalis flap negates this complication. So immediate post-operative, we have to counsel the parents that children who are undergoing a sling surgery will have lag of thalamus for quite a duration of the time, and they have to be very strict with their lubricating drops and ointment. But who is at risk? Especially people in old age because of their inherent poor Bell's phenomenon. Patients with CPO and double elevator palsy are at greater risk. Suture granuloma, not very frequently encountered. It is a reaction to suture, most commonly in the posterior approach surgery, and we have to remove the granuloma with normal scissors and the base has to be cauterized. Abnormal lid contour, of course, we will have to tackle it only by doing a redo surgery. Extrusion of the sling, it can be due to infection or it can be due to a foreign body reaction. So we can see that on the left, this boy has not actually, there is exposure, but there is a lot of infection going on in the whole sling tract. And it is, whereas on the right, we can see the child one side with an abscess and the other side with a extruded sling. Another patient with no evidence of infection, but an exposed sling after several years of surgery. Conjunctival prolapse occurs in a severe congenital ptosis where the dissection was carried out beyond the fornix or due to the excessive postoperative lid edema. A simple lubrication would work in these cases, or if need be, the conjunctiva has to be deposited with a muscle pool. The Pang, if the conservative measures do not work, then the Pang sutures, which is nothing but non-absorbable sutures through the conjunctiva, through the desired skin crease, are taken and left for 2 weeks. An entropion usually encountered after excessive tarsal resection in Facinella cervix when the anterior lamella is too long relative to the posterior lamella and the skin is not attached deeply to form a skin crease. The treatment would be to shorten the anterior lamella by excising a short strip of skin above the incision. Whereas the converse is true for ectropion, the anterior lamella is shortened too much, and or if the sutures are brought out too close to the lashes and tightly. So the skin below the incision should be undermined, recessed, and sutured at a lower level on the tarsus. Lash ptosis occurs when there is an aggressive dissection of the orbicularis muscle from the tarsus along with suturing of the LPS high on the tarsus. The treatment would be a gray line split with a formal skin crease formation, ensuring the suturing of skin edges tightly on the LPS or tarsus. A rare complication would be injury to the superior rectus muscle or a superior oblique muscle. To conclude, ptosis surgery is more or less a cosmetic procedure than a functional procedure, and we have to counsel the parents and the patients before surgery in order to have their realistic expectations so that we can handle the complications, if any, in a better way. Thank you for patient listening.
Thank you, Dr. Jaya, for a very thorough, complete talk. Dr. Vidya, can you take some questions?
Yes, madam. Jayagayathri, that was a wonderful talk. And I'd like to know the opinion of the expert members. What is the likelihood of adjustment over time? Like considering factors like changes in patient anatomy, natural aging process, and also unexpected variation in the sling tension. And how do we achieve optimal and sustained lid elevation? Santosha, could you please?
Yeah, I think that is a utopian goal to achieve constant correction or have a very durable procedure. That is almost impossible, especially if you operate earlier. So if a child, if you operate, then the chance of the child having undercorrection over a period of time is very high. If you operate in a stable adult, fully grown adult in the late second decade or third decade, then the chance of having a durable surgery is very high. So depending on when you operate and what is the etiology. If you operate on an elderly patient with, say, acquired aponeurotic ptosis, again, it's going to be stable for several years. So in a child who's growing, there is bound to be some kind of undercorrection over a period of time. And also, if you have done sling, the chance of undercorrection is very high in a child when he grows into an adult, as opposed to levator resection.
Yes. And another problem is that dealing with lag off, which can be a persistent issue following sling surgery, or it can be levator excision that we have done for a Marcus gun jawing phenomena, or it can be following a frontalis flap also. So what consideration should we keep in mind, sir, and how do we effectively manage this situation?
So only consideration that you can actually, as a precaution you can do is Shermer's test and assess Bell's very carefully and exclude the possibility of patient having any monocular elevation deficit. If you have excluded all this, then the only way you can deal with lag of thalmus would be adequate lubrication, especially at bedtime. Taping is hardly ever required. I really haven't advised any patient nocturnal taping. But lubricants, many patients are still on lubrication even after 3 or 4, 5 years following surgery. Nighttime gel on the cornea if they have severe lag of thalmus. The possibility of lag of thalmus is higher if the patient has poorer levator action and if your resection is, supramaximal or maximal, and in patients who have undergone a tarsofrontal sling as opposed to any other form of surgery, including frontalis flap, the lag of thalmus is going to be much lower. Patients who have undergone a mullerectomy or fascicular severt procedure are going to have much less lag of thalmus than patients who have undergone maximal or supramaximal levator resection or Whitnell sling.
Does age also play a role in this, sir? Like if we do age also play a role in this, sir? Like levator excision, if we do at an early age for Marcus Gunn jaw winking phenomena, does it have an effect on lag of that the patient?
Marcus and jaw winking phenomena,
Yes.
if you excise or extirpate levator and do sling, then it will operate just like any other case of sling.
Okay.
Right? So obviously there will be more of lag of thalmus and down gaze slit line.
Thank you.